waste time, so let's get started. I am Aya Goto, Director of the Takemi program in International Health, and today I'm very happy to have one of our colleagues presenting in this round seminar. And in this seminar, I have to say, as always, speakers' remarks are based on their own scholarship and experience. As such, they speak for themselves, not for others. Okay, let me introduce Anya. She is a pediatric dentist by training, and she's a senior researcher at Cruz in Brazil. It's like a mecca of community health. And she has been doing research on health services evaluation, access to health services, and violence. And she works, I really like the point that she works very closely with primary health care workers. And today she's going to talk about them. So Anya, floor is yours.
Good afternoon, everybody. Thank you for taking part of your lunchtime to be here with me today. My name is Anya Vieira Meyer. I'm a researcher in Brazil at the Cruz, and here I am at the fellow.
You better keep it also. Yeah.
Anyways, so today we're here to talk about COVID-19's post-pandemic impact on primary healthcare workflows in Northeast Brazil. The idea of today is to talk a little bit about pandemics, Brazil health system, how primary healthcare and COVID happened in Brazil, the bit of the primary healthcare and its impacts on the post-pandemic period, and then the challenges for the future. So pandemics are not new. Found them for years and years and ages. This shows the impact they have on people's life. Just for us to have an idea, one of the biggest one killed more than 200 million people. COVID is around those 2 years, so around 7 million people. Nevertheless, it's a very, very important latest threat in our recent years. So it affected pretty much the whole globe, and it killed more than 7 million people. Knowing the pandemics are not new, knowing that they are always already around, before this pandemic came, there was a study that tried to show how countries and health systems around the world were prepared for future pandemic. Interesting enough, two major players are United States and Brazil, showing that how good we were within the pandemic. But just very quickly here as a footnote, if you look down here on the group, you see that the two countries who had more deaths are exactly Brazil and the United States. So that's why I think it's important to understand a little bit about the system in Brazil and why we were out there and what went wrong, right? And if the effects that we had during COVID is still there or not, which is pretty much our aim today. So I'm going to talk and ask a little bit of patience me to talk about the Brazilian in-prime health system, which was created in 1988 with our latest constitution. It's organized the primary health care through family health strategy, which then is mainly managed in the municipalities. So it's all decentralized. The idea is if primary health care is close to the municipalities, it's close to the people, it's easier to understand their issues, and it's also easy to plan according to the local. It's team-based, and that's another big difference between Brazil and other primary health care. In Brazil, the teams are doctor, a nurse, a dentist, health auxiliaries, and human health agents. The majority of other systems would have the doctor as the main. And in some places that have community health agents, they'll be volunteers and not completely inserted in the health system. In Brazil, they are part of the health system, they are paid by the health system, and they're supposed to work together in this team in a territory and responsible for a certain amount of. So they should be very close to them. And the health agency itself, they work and live in the territory. So above anything else, they really understand what's going on in the field and they understand what's going on in the health system. Therefore, we believe that they're very good informants of what's going on. And that's why most of our research is based on that. In order to do this research, and actually a team of researchers in Brazil, we are about 20 of them, decided to get together and study primary health care and the impacts of COVID. We actually started to organize ourselves in 2019, right afterwards COVID came into stroke. And mainly we are divided in different municipalities, eight state capitals and 4 state capitals and 4 inner cities in the northeast part of Brazil. And for those who don't know, Brazil is divided in 5 regions. The 2 forest ones are the north, where the Amazon forest is, and the northeast, where we are. And what we've done so far, research-wise, the whole team, we collect data, we analyze data, and I think most important, we have been working together with the community to do a lot of mitigating effects. So it's not only working with the community, with the health agents to think the research, to analyze the research, but once the results are there, what we can do to mitigate or to make life better. Today we're not talking about that, but it's a part of the research I'm so happy about it. If someone wants to ask later, we can do that. But we're here today to talk about primary healthcare and COVID. So this team worked, and among the research we've done, talking with 1,900 community health agents in this area in the northeast part, we noticed that about 80% of those were in the front line for COVID. Unfortunately, though, only 19 or 16% received training for the COVID. And when we looked into about gears for protective, only about 14% of that. And this, together with the organization of the country, especially the lack of guidelines from the federal government to the states and municipalities, end up having a big effect on the activities that were done with reported by the health. For example, they stopped doing home visits, they stopped doing health promotion activities in school, specific groups that they used to do in the community, and other sites as well. So the pandemic did a reconfiguration of the health system, affecting very, very strong. This is another way of seeing the same data. So about 4 out of 5 health agents were in the front line, 83% did not receive training, 80% received changes on the organization of the health system. And very interesting, about 20% of them felt that their violence influenced the work process. We're going to talk a bit more about violence because that's a big issue where we come from. We also decided to look into the quality of life and the mental health of those agents, believing that if what's going on affects who you are, this also ends up affecting your work and your ability to care. So, and we try to understand what was affecting that. So if you look into the capitals, said before, capitals and 4 inner cities, the loss of quality of life were related to poor mental health, lack of training, uncertainty about occupational safety, and lack of adaptation of the service. In the inner cities, we saw that the coronavirus anxieties, poor mental health, lack of adaptation, lack of training, and lack of personal protective equipment were related to that. Meaning that a lot of the things that in the work that they were involved were affecting their quality of life. And then in turn, most likely affecting their ability to care for those that are in the field. Anya, you keep talking about their work, what they do, what they're supposed to do. So very briefly, very limited here, I'm going to say the most common things that health agents do, and also what we very commonly see being done in the forum on the health units. So community health workers will do home visits, and for that, they will go to see if people are getting vaccinated, if they're a pregnant woman in the field, and that need to be brought into the antenatal care. They will be understanding if there is a TB, if it's an elder that needs a home visit from a doctor or a nurse. They do a lot of health promotion activities in the community, health promotion activities in schools, serve other types of services in the community, and within the health unit for the community. And on the other side, if we looked into the health units and most of the other health professionals, we see they're doing prenatal care, diabetes and hypertension, oral health care, child care, especially in the first years, vaccination, cervical cancer prevention, and on demand. So what are the effects of COVID on that? So we started asking the health agents. So was that any impact on what you guys doing and what the health units are doing during the COVID? These are data from one of the municipality on their perspective. I'm going to show two groups of activities. The first group, I don't know if you can see the red lines quite big. It's saying that they diminished the amount of things that they were doing with COVID, compared to what they're doing before. So with that, we see there is a huge diminish on activities in the schools, activities in the community, in groups done by the health agents, and also preventive oral health, family planning, child care, and diabetes and hypertension in the health unit. But this is their opinion. When we look into the real data, and here what we have is the number of consultations, the number of activities related to each one of them, real hard data from the same municipality. And see that on the first wave, it's this big drop here. You can see for diabetes and hypertension, we pretty much stopped the city. On the second wave, we had a big hit. Each one of these lines is a different region of that city. So we can see that it agrees, let's say, with what the health agents say, but we also see that the way it affects it was different depending on which area of the city. And you see also that it will depend on the kind of activity that we're talking about. So when we talk about child care, we see again a big drop on the first wave, a second drop on the second wave, but they don't go as deep, and the time that they come up is also different. Same thing we see for cervical cancer and for oral health. And then we have a second group of, let's say, activities done not only by the health agents, but by the health units that have were affected, let's say, differently during COVID. So when we talk about home visits, for example, you see that the reds are not the ones that drop the most. So most of them will say that they maintain the amount that they were doing during COVID compared to what they were doing before COVID. And you can also see this for what the health team were doing. So we are looking here at TB, lepra, vaccinations, prenatal care, pregnancy tests, that the majority of them saying that these things were being maintained, even though the COVID was there. And again, we see this on the hard data. See that they don't drop down to zero as we saw in the previous ones. So what I'm hoping to continue to be showing is that, so we have differences in how it affected. And these differences were also not homogeneous on the different regions. So depending on the activities and depending on this. Walk-ins was the other way around. So everything else stopped or had an effect, the walk-ins increased. And that's not very different from data from different parts of the place. What I think is interesting for us to see is decided to look into some of the things that were going on, happening in the field that may explain this diversity. And one of the things that caught our attention was the violence. So we noticed that in most violent areas were where home visits, for example, were dropping more. And these were also where the COVID was killing more. And I love these graphs because right here in the middle, with the red and yellow, you see the mortality rates due to homicides. So where it's red there, in the 5-year time frame is where people are being killed, gangs, by violence, by crimes. And what you see here on your left-hand side is the interference of COVID on school activities. And you see that's pretty much, you almost can overlap one thing with the other. It's also the interference with the COVID with community services in the neighborhood. Again, you can almost put one thing on top of the other. This is an atlas that we're going to be publishing soon, this whole group. That you guys know, so hopefully we'll be able to finish. But you can see that there is a relationship, unfortunately, because in the most vulnerable areas where we need the health agents the most, where we need the health systems to be working the most. And I think a very important point that needs to be done, which I forgot to do earlier, is that in a lot of those places, the health agent is the only face of the state that the population sees. The policemen are seen as a scary thing that they don't want to come in. You know, sometimes the schools are not there the way they're supposed to. So the health agent is the face of the state, but is not being able to get into the violence. And just bring a little bit more violence into the talk. 43% of our health agents felt threatened by the violence during the work. About 20% thought of changing profession because of the violence. You can see that 41% thinks the violence in the territory affects their physical health, 64% that affects their mental health. And for me, very striking is almost 30% stopped caring for families because of the violence. And about 56% believe that violence interferes with work performance. So that's a huge issue, and is not going to be solved by the health system by itself. Why we're talking so much about violence, it is just the northeast part, it's just Brazil, unfortunately not. Latin America is a huge historical, especially the last few decades. And this report shows that homicide rates were higher than 10 per 100 inhabitants. This was already like 10 years ago. And that they're saying that 10 per 100,000 inhabitants is an epidemic level. That's what the World Health Organization. And then if we looked into Brazil, among the 50 most violent cities in the world, we always have a few our cities there. The last year there were 11. Where are they? In the Northeast mostly. And if you look into the data here, the size of the dots, of the orange dots, are the size of the epidemic. And remember the 10 per 100,000 was already an epidemic. Well, we're talking about here of 49 to 62, 37 to 49. That's the homicide rates that we're seeing in this region. So that's why it's so important for us to understand how this is affecting everyday life and including the health system and its capacity to provide care, especially when we have something else coming on like the COVID. The way we think and we believe that this is working, that this is still a working program, so take it with a little bit of caution, is that what the health agent hears about the violence or sees about the violence, as well as what he suffers, and because they just suffer violence when they're there, affect their perception of violence, in one sense. And this is related to their mental health. So if my mental health is bad, I perceive more, but also if I perceive more, my mental health gets affected, which again is related to the coronavirus anxiety. Coronavirus anxiety is related to this environment that the health agents were able to work on during COVID. So this COVID environment work has to do with that I had protection, was I trained, things like that. All those things then related to the activities that they do, especially the ones that they do outside of the health unit. So mental health, my perception of violence, and the work conditions I have. As I said, so what we understand that's what's going on, is still going on. It's a polycrisis or a syndemic word, my vocabulary, the syndemic, because pretty much means that, and we know that disasters exacerbate social determinants that were already in place, and when COVID hit, we already had a lot of other issues. We had a decline in social connectivity, we had low social capital, we had political crisis, we had urban violence, social issues that with the wave of COVID, became worse. And even though I'm not talking much about political crisis here today, again, it had a huge effect in what happened in Brazil during COVID. Okay, talked about COVID, talked about what happened. Some of this is already published, no news. We're here to hear about what happened after this. And that's why I wanted to show you this data. So we collected data in 2021. We also collected data in the second semester 2023, when the World Health Organization has said that the emergency due to COVID was not more a threat. So it wasn't, we can understand that this is not a pandemic anymore, not the way it was. And we asked health agents, okay, are you doing home visits? Are you doing health promotion activities? Are you, and when you see here is that they're back doing what they used to do, right? So here is yes, no answer. That's an important issue because it's a yes, no answer. And this is all significant. So we pretty much go back to where they were doing before. And when we ask even about the different types of home visits, by the mental family, for family registration, for active search of pregnant woman and things like that, again, they all go up. And this is all very significant. But then when we ask, compared to what you used to do before COVID, how much are you doing? And when you compare 2021, when a lot of them said, I'm doing much less now than I used to do. Well, my expectations were, well, in 2023, they're back, so the maintenance bar would be higher. Or even in a better situation, we'll have an increase to compensate for things that were not done. But what we see, unfortunately, is that the decrease bar is still there. So there is something that's going on. This reconfiguration that happened during the COVID, micropolitics, like, oh, I don't know, but it's still there. It's still affecting us, even though more than 3.5 years later, COVID started. And that's for a lot of things. This is coming from home visit. This goes to health promotion within groups. This goes to school activities. This goes to community service. You can see this throughout. And this is very important, community monitoring activities. And what's going on there, we're not sure. My personal belief is that the violence has something to do with it. I also think that the way the micro powers in the municipalities, all this reorganization during COVID, still there. And then it's hard to put people back doing what they were doing before because they got used to doing less. But I think there's a lot of things going on together. Sorry for showing you this, but here the main point what I wanted to say is I showed that there was a difference between how it affected the COVID geographically and also depending on the type of the activities, right? And what I'm trying to show you here, each one of those lines here is a municipality, right? And the green is 2021 and the blue is 2023. And then we have lots of questions here. But maybe what I want to show you is that the municipalities are not the same either. When we looked, for example, here on the first, asking is violence present in the community that you work in? You can see that Fortaleza, for example, goes from 83 to 92, while we have a drop in Teresina from 90 to 88. I don't even know if I can say that was a drop, but you know, and there are Crato goes from 56 to 46. Even though this is different, and in some places is increasing, and some are decreasing, what strikes me is the percentage. You see that with the exception of Barbalha and Cat, which are the smaller cities in this whole, all the others have values that are 12 to 50% of the violence. If you look, for example, at the common types of violence, then the inner city, which are the lower four here, the domestic violence seems to play a more important role. Then urban violence, which is the third one, the third column here, which are more common in the larger capital municipalities. So all those differences will also play differently in the territory. It's not only where the community health agents are, how the health system is organized, but also the dynamics that are going on in each one of the municipalities. If you stop visiting, assisting families due to violence, again, we have a very big number. In average, almost 30% of our health agents are saying that it stopped, and they continue have stopped, right? Because in 2023, we had 29.8% of them overall saying that. If you believe that violence affects your mental health, again, you have 62% of them in average. And it hasn't really changed much from 2021 to 2023. And this, I think, are very, because if they're affected there, it's like we're stretching. It's going to get a point that this is going to break. They're really not going to be able to go this relationship. So it means we have lots of challenges in the future. And for those who are not aware, this is a schematic map of Brazil, pretty much showing that COVID made the inequalities even bigger, right? And that's, remember that slide we talked about the polycrisis and then syndemic, that's it. Things were already there, but they became worse. You can't blame all in COVID. We already had a system there that wasn't working properly. There had a lot of cracks in it. But the importance for us to understand is that the distance in Brazil is unfortunately top in the ranks of inequalities in a lot of things. And so these differences are making worse. And COVID is helping. This paper came out last week. It has nothing to do with Brazil. It's actually talking about the British system. But what I brought it here was because this author talks the new models of primary care risk are exacerbating existing inequalities. And I think that this new way of doing primary health care, and this was not due to policies, this was not due to maybe the lack of them, because we had a government for years that did not invest in primary health care, and maybe we're now getting the results of that. Maybe that's some of that, but it's not an official policy. But this, what's going on, what happened throughout COVID is affecting our ability to diminish inequality. And we need to reorganize, we need to rethink, we need to rebuild things. So one of the main take-home messages that I would love you guys to bring home is that COVID did not affect primary healthcare workflow in a homogeneous ways. So we had work processes differences, so the activities were affected differently. Geographical differences as well, depending on the city, depending even within the same city, how things are. And there are some hits of things that might be related to that. More in rural areas, more poor areas, lower social demographic index are related to worse performance. And it's important for you guys to know that those areas is where we have higher coverage of primary healthcare. Because by design, that's how Brazil healthcare is organized. The poorest areas, we have higher coverage. So we can't say that's because it's not there. And exacerbating previous inequality. Question mark there, because it's my personal belief. Our data doesn't quite support that, but I think we're looking towards the same direction. And the other take-home message is that work process did not return to pre-pandemic level. And is this reorganization of primary healthcare is definitive? I don't know. Maybe if we are able to redo this in 2 more years, we'll be able to see, well, it's going towards a better trend, or it's getting worse, or something else that we blame the COVID as it is going on. Maybe if we changed our financial way of organizing the system, maybe if we talked more about the better training for human resources, whatever. But there's something is going on that we need to dig in to better understand. And there's a rupture there that, again, we need to put things in a better track. What we need to do, for me, we need to strengthen primary healthcare to make it more resilient. And it's not only more resilient for future pandemics, this also because as we started this talk saying, they're here, they're coming back, there will be more pandemics. And another thing we've noticed looking into the human history is that they're getting closer to each other. Before we had to wait centuries or sometimes several many decades. Now they're catching us years. But we need to understand the roles of politicians and health professionals in organizational systems. I didn't talk much about politicians, but we did know, and I think this country, my country, know how those things didn't quite work the way at least I expected, and how they can interfere for the better or for the worse. We have examples around the world for that. We do need adequate infrastructure resources. We do need to have adequate human resources training. Having that does not mean that we have quality, but without that, we cannot have quality care. And then with the inequalities and the health outcomes, will just keep getting worse. We need to care for caregivers. We need to give them support. We need to make them able to do their work. Don't care for them, then we have a huge problem. And we need to understand and act on the fact that other issues not directly related to the health system do affect the health system in a very striking way. And if we wanted to get into a better world in the future, we need to work with all those. And with that, I'd like to thank you and say
Thank you very much for a very interesting explanation of how healthcare workers work during the pandemic and post-pandemic. I believe that I do have many questions, and I do believe that many of you have questions, comments, so please.
Thanks, Anya. So you've shown well the very strong social determinants on COVID. And also at the beginning of the talk, you were saying that there was like clearly, as we all know, lack of leadership in the federal government. Do you think that there being a different federal government in position could that the social determinants have been less strong than which one is basically you think it's a main driver?
it's hard to
What's your intuition?
it's hard to say the weight, but I have no doubt that if we had had a leadership in a leadership health, because I end up not talking much about our systems, even though health teams are managed in the municipalities, we do different in other parts of the world, like Argentina, for example, which the states are very independent, or even here, we do follow guidelines from the Ministry of Health. The lack of those guidelines end up happening. So we, in the Northeast, a lot of the state governors got together, made their own teams, and they started to have guidelines for the Northeast because they decided to. But this lack of organization on the federal level, I have no doubt that it made more gaps than we had. And as I do not have any doubt that if we did not have our unified health system, with all the problems it has, so finance, problems with human resources and everything, if we did not have we would probably be above the United States on the number of gaps, because it was with all its issues what kept the country and a lot of lives in the country. But to say how much is due to the federal government, I don't know, but I'm quite critical on the lack. It was just completely, this is not a problem. Come on, guys, let's go to the streets. Let's go to work. That's what we need to keep our economy going. So bigger, better issue.
So firstly, thank you for a fantastic talk. This was fascinating. One thing I was thinking about was staff turnover, in that, you know, is this the same people all the way through, or was there kind of an exodus during the pandemic such that even if there's the same number of health staff now, they might be newer or less experienced?
Health agents, in general, here they've been into their work for 16 years. So we have health agents that have been there for like ages. We do have a problem with turnover with doctors. Most of those municipalities have civil servants working in the health sector, and they have to do a test to get in. So once they are there, they're happy to be there, with the exception of the doctors, which have a bigger, but not with the health agents that we see here. And I don't have the data, I'm going to say just from my gut feeling, but I do have medical doctors here from the primary healthcare in Brazil. I did not see a huge exodus of doctors due to COVID. We had this problem, like we had mass medicals in Brazil, which tried to put medicals in places that the Brazilian doctors don't want to go, and we had the first wave of that in 2013, 14. During again the past administration, this was put aside. We're having a second wave of that again that started last year, 2023, 2024, with more mass medicals, which means between more doctors into place there. But I don't believe, as literally I believe here, that what we are seeing here has to do with the turnover of the.
Thank you, Anya. You started by saying that according to the measure for preparedness, right? Brazil and the United States were highly prepared, but after the pandemic hit, they each had among the highest numbers of deaths in the world. So was the measure of preparedness bad? Was the measure of preparedness not related to actual ability to avert death? Or was it some other factor, like they both happen to have crazy presidents in power or something like that? So what's your, I had hoped for an explanation.
Okay.
Why, was the measure of preparedness wrong? Maybe it needs a discount, a political discount factor?
I think, and that's just, again, me personally, what I believe, that the measurements that was done before focused on the health system. So in the case of United States, do you guys have money? Do you guys have hospitals? Do you guys have human resources well trained? You have all the equipment there in place. In Brazil, you have a unified health system, you have things, so it looked at the system, like the health system, but they did not take into consideration, which I think, and that's what I try to push the point here, that there are a lot of other things that interfere with the health system. And unfortunately, just to paraphrase you, crazy governments to make a huge effect on health systems. I cannot say anything about the US government. I will not speak about that. But I think the first point here is that understanding the role of politicians and the health professionals on or hitting a pandemic. And what we saw back home, and I believe maybe this was seen in other countries, maybe in the United States again, no, not from here, I don't wanna put my neck there, but is that this was not, this relationship that's supposed to be involved of the population were not in the same path. They didn't hold hands as they think they, and maybe the index did not account for that. I don't know, to be honest. How would they be able to account for that logically?
An alternative proposed index.
No, I'm afraid not.
That's what I would in this case.
Whose index was it? Sorry.
Oh,
Whose index was it?
it was actually quite well known, okay.
Is that the Oxford index?
Not Oxford, it's a bit.
Hopkins? Baltimore? There it is.
The visual capital global pandemic preparedness.
Visual capitalist.
Visual capitalist?
Yeah.
I can dig better the index data. Send it to you.
Thank you so much.
But sorry, but I don't know if you want more information as it didn't get anything, right? But
Yeah, I wonder, you mentioned that despite the decentralized nature, there is a line of command. So how much of the decline in home visits versus in my field, hypertension, diabetes, was in a command from above, we have social restrictions, don't go, versus the model, the way you talked about it is like the agency of the community at work there, the violence, etc. They decide, they wake up this morning and they say, oh, this is too risky now, I'm not gonna go out. Because the diabetes hypertension goes literally to zero. So I wonder if there was a command from the top and said, we are not doing that, let's focus on COVID for now. Maybe.
So there are two up-down comments, let's say. The first one is the big guidelines come from the federal government. And for what you're asking, I don't think this is we're talking about now municipalities. And the municipality I talked more is Fortaleza, is divided in 6 different regions, but it has a health secretariat. There, for example, for prenatal care not to stop, it was them saying, we're not stopping prenatal care. We're not stopping vaccinations. We're not stop. So the second round that say we're not stopping those things. For diabetes and hypertension at the time, they said, okay, we're going to people a lot of the time if they have hypertension, they come to the health agent, unit to get the prescriptions, and they said we'll just do automatic prescription. So like this, we'll keep these people coming to the health unit to do that. This on the health unit side. For the health agent side, they're supposed to be in the streets. They're supposed to be doing more visits, especially to say, people here, wash your hands. You need to use masks. You need to keep a distance. You need to do this and that. That were the guidelines, but they did not get training for that. Plus, they did not get gears for that. A lot of those health agents for the first trimester of the pandemic, they were in risk groups, diabetic, hypertension, age, and everything. So some of them were put aside. And I have to say that part of that going down had also to do with less people in the streets, but I don't think it's a coincidence that thinks the numbers are worse, but the violence or the vulnerability is worse. So that's what I'm saying. There's other things that are playing a role, but this social numbers, so inequalities, in my point of view, it's also playing a role. It's hard though with the data that we have to say the percentage, how much is due to violence, how much is due to this, how much is due to that, because even in a city like Fortaleza, the different regions change slightly here and there. I don't know if you notice, for example, sorry, I actually, because of the time, I didn't show you this. So here's the home visit, and this is where the violence is. This is where the violence is, but here the home visits didn't diminish as much. This is a region called Regional 5, and here the local area said, we're going to buy extra gears. The little that were trained, most of them were trained here, most of the gears were getting here, and they would said you have to go just to the street in any case. I don't know how good it is because some of them had to go without, even though there was more training, it's still much less than needed for the population. So, but again, this the guidelines do interfere. I have no doubt, but we need to do that with care for those who are caring.
Thank you. I have one question from participants online. Kazu, would you like to speak up, or is it better that I read? He's attending, I think, from Japan, and it's nearly 3 o'clock.
Okay, Kazu, thank you. Kazu is was a Takemi last year.
Yeah, he was.
Nice to hear that you're here with us.
I think.
Yeah, thank you. Anya, can you hear me?
Oh, okay.
Yes,
you hear
I
me?
hear you. Great
Oh,
to hear
really?
your voice.
Oh, this is a different question about your slide, almost the end of your slide, that about the new primary care models, about digitalization, and they are not enough for the Brazilian. Is that true? So my question is, do you believe digitalization is unsuitable for Brazilian systems? Well, because in Japan, especially in primary healthcare, manually sharing information is a huge problem. Huge problems that we cannot share enough information of patients between the hospitals or sometimes between the clinics and general hospitals. So we need digitalization in primary healthcare. So do you think that digitalization is not good for the Brazilian?
I think you're talking about this slide, just to make
Yes.
sure that we're talking about the slide of this one,
Yes.
right? Okay, so this slide has nothing to do with our work, and the reason that's here is just to say that this reorganization of health system, sometimes it increases inequality. This specific paper is in Britain, and what they say there is that because of the austerity and all the shock that COVID had, they had to do a lot of changes in the provision of healthcare, and among them is that people would reach healthcare through digitalization, through computers. And by doing that, they believe that those that are electronically illiterated, those that are elders, those that they will have more difficulties to search. So what this paper is talking about is that some changes due to COVID might actually be increasing inequalities. This is definitely not the case in Brazil. We are still struggling. We do have actually a quite good system on the information system in the country. We're improving them a lot. We're not on the case. The changes that happen in Brazil do not include the changes that are being described here in Britain. So I don't think that's like for us, this is not an issue right now. But I brought this paper here just to talk with our conversation, saying that this reorganization that is happening in Brazil, not through policies, it's happening in Britain, it's probably happening in all of the countries around the world. We need to be careful how they are happening in order to not increase inequality in accessing. So that was the reason they put it here. Hope I answered you.
Okay. Okay, I understand what you're talking about. Thank you. So just one thing, you don't think there is not issue in Brazil that having a digitalization in primary healthcare is not important right now?
No, I'm not saying this. What I'm saying is the digitalization that's going on in Brazil right now is of the treatments of the patients receiving, but not right now in Brazil. People are not accessing the system through digital means. Right now, that's not how it works, at least not in a public system. So that's not, when I say that's not an issue, is that if we have other problems before to get to that problem. I think if Brazilians had to get through the health system, through electronic devices, this will be a problem as well, but that's not how things are happening right now there. The digitalization process that Brazil is going through now is through the records, patients' records, is to making sure that we know where the patient is to make sure that we can send a patient from one point of the care to the other point of the care, making sure that it comes back. And this, I think, is a great way of working digitalization and having the informatics on our side. This is the kind of movement that Brazil is doing right now, and I think is a positive.
Thank you, Anya. Thank you.
Okay, thank you, Calvin.
Yeah, thank you for a great talk. You on your last slide, you mentioned that one of the questions going forward is to learn more about the ways that political leaders intersect with the health system, interact with the health system. And I mean, it's very interesting. You have specific sort of research questions in mind, or is it just a broader research area that needs?
Right now, it's just a broader thinking that how we work. I really don't know, because again, I don't think it is aligned. It's back and forth. It depends on so many things. But just for example, there is a paper that when we started primary healthcare in Brazil, and the uptake, the coverage, we found out, there's a paper from Marcia Castro from here and Monica Viegas, that they show that the alignment between the mayor and the state governor made the increase of coverage faster. So sometimes, to be honest, that's something I wouldn't think to start with. Oh, this will affect the increase of access. So we need to think of different ways of understanding all those issues. And in Brazil specifically, we have like 40 different parties. And nowadays, it's hard to say what each party really believes because, so it's not like here that you at least theoretically know what the Democrat represents and what a Republican represent. In Brazil, we can't say. So there's lots of things there that can be explored. Don't have a specific question like that. But we do need to understand better. Otherwise, we'll get stuck again in a different pandemic.
Okay, do you have a question regarding this slide?
Okay.
You say that our work processes did not return to pre-pandemic levels. But my question is, does it need to return to the pre-pandemic levels? Because the reason why I'm asking is that in one of your slides showing proportion of increase, I saw, for example, delivery of medicine, that increased substantially. And I think because of what happened during the pandemic, some community health workers, primary healthcare workers are taking maybe new tasks that they found. So it doesn't necessarily, I think, need to return to the pre-pandemic.
First thing we need to say is that before pandemic, things were not great.
Okay.
To start with, it's not that we say pre-pandemic everything was fine, in the pandemic. No, we still had a long way to go. But now we kind of went back 20 years, and now we have to keep rushing now. I understand and I agree with you that some of the work processes may need or need to be done. And one of the things, for example, that we noticed regarding health agents is not part of their core activities to accompany doctors and nurses and dentists to home visits. It's not. But if you ask nowadays one of the activities, they will say this. And the reason doctors won't go into the territory if they were not with health agents who knows it's safe to come here, who had asked whoever they need to ask if they can get into that street. It gets to that point, unfortunately. So a lot of the time that the health agents should be doing his own home visit, or he's accompanying a health doctor or a doctor or nurse or something. So I agree with you that some things may change. Having said that, there are core activities like home visits, like activities in the community, like activities in the school, that they need to even get better than they used to do. And that's not what we're seeing here. I agree that we're always evolving and maybe we learn some stuff, but I don't think that the data I show here is a result of evolvedness. I don't even know if that word exists. Of the health system is more related to a rupture or reorganization that's not evolvedness.
Okay, thank you very much.